Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Thanks everybody for joining us this week. A big thank you to Dr. Ruanne Barnabas for joining us again on ECHO. Dr. Barnabas has chosen a topic, and I'm just really appreciative she's chosen this because we don't talk about it enough. So thank you for diving into HIV and menopause. Dr. Barnabas is one of the providers in our Madison Clinic and faculty here in the Departments of Global Health Medicine and Epidemiology, and thank you for doing this.
You're very welcome, Brian. Thank you so much for this opportunity, and good afternoon, everyone. So I wanted to talk about HIV and menopause today because the question came from one of our patients, as so many of our good questions do. I have a patient who was going through menopausal symptoms and wasn't happy with the few interventions that I was offering. I took the opportunity to read up on the current literature on HIV and menopause and wanted to share my findings with you today and welcome the opportunity to hear about your experience as well. So we expect that with antiretroviral therapy, HIV positive persons will live as long as HIV uninfected persons, and the consequences of living longer with HIV include both the exposure to treatment and the conditions that increase with age. And so women who live with HIV and live longer will experience hormonal changes. They have an increased incidence of cardiovascular events, an increased incidence of non-AIDS defining infections, renal disease, non-AIDS defining cancers and malignancies, muscle and skeletal changes, non-AIDS dementias, neurocognitive changes, mood and CNS disorders. So we expect to see more of these in our clinical practice. So the menopause, which is defined as 12 consecutive months of amenorrhea, not related to a surgery or other obvious cause, is what we're talking about, and the age at which natural menopause occurs is a marker of aging. So late menopause is associated with overall survival and greater life expectancy, reduced all-cause mortality, reduced risk of cardiovascular disease, stroke, angina after MI, and atherosclerosis. You also experience preserved bone density and reduced risk of osteoporosis and fracture with a later age of menopause, but an increased risk of breast, endometrial, and ovarian cancers. So with those data in mind, it was surprising and uncomfortable to see the study that showed that 26% of HIV-infected women experienced early onset of menopause. So, and here the definition was less than 40 years compared to 10% of HIV uninfected women. Now this finding is not consistent across all studies, but it is something to note. So with the earlier onset of menopause among HIV-infected women, we can expect to see a higher incidence of menopause-associated comorbidities. There are at least 3 potential contributors that have consistently been associated with early menopause among HIV-infected women, and these include immunosuppression. And here the threshold used by studies was a CD4 count of less than 200. So here a CD4 count of less than 200 was associated with early menopause. Smoking consistently among both HIV-infected and uninfected women can cause menopause to occur 1 to 2 years earlier. And then markers of low socioeconomic status, low level of education, unemployment, and poverty have been associated with early menopause onset. While studies have tried to adjust for this, it's of course very difficult to completely remove the confounding with access to healthcare. So while these factors have been shown to be associated, we can certainly think about bias in the way studies have done for markers of low socioeconomic status. Inconsistent factors are race, ethnicity, BMI, body composition, physical activity, and diet. So the evidence behind those factors is really not very strong. So the menopause is marked by falling levels of estrogen and is associated with an increased risk of cardiovascular disease, diabetes, osteopenia, and osteoporosis. And the early onset of menopause, here the definition is before 46 years, increases the risk of these diseases and may be linked to higher mortality. There's really no difference in the way you can assess reproductive aging between HIV negative and HIV positive women, and I'll leave this slide for you to look at it in your own time. But just to say, you do see the sustained increase in FSH. You see a rapid decline in estradiol, and the same predictors that you use among HIV negative women, you can look at them in HIV positive women. So here's one of our audience participation questions. So you see this decline in estrogen, and this has significant cardiovascular effects, which include either A, vasodilation, B, prevention of smooth muscle cell proliferation, inhibition of LDL deposition in the vascular walls, inhibition of platelet aggregation, and stress-induced endothelial injury, or all of the above. So which are the effects of which we see with estrogen? Excellent. So all of the above. So with this endothelial dysfunction, which is associated with a decrease in estrogen and a decreased flow-mediated dilation, women experience hot flashes and also higher levels of aortic calcification and thickness of the common carotid artery. The other common symptom is vaginal dryness and sleep disturbances, and these three symptoms, hot flushes, vaginal dryness, and sleep disturbances, are the three classic symptoms of menopause. Also described are mood disorders, generally depression, and decreased quality of life, although studies have not consistently found the last two factors associated with menopause. It's really the first three that are most commonly found. Here's another question associated for the audience participation. And so we talked about the increased risk of osteoporosis and fractures. So what are the current recommendations for evaluation of bone disease among HIV positive persons? So A, screening for osteoporosis with a DEXA scan in men over 50, a DEXA scan for postmenopausal women, a DEXA scan for HIV-infected women with a history of fragility fracture, persons who are on chronic glucocorticoid treatment or at high risk for falls, or all of the above. Great. So yes, all of the above. And this is because you can see in this figure with late perimenopause and postmenopause, so that's in the yellow and green colors, a greater change in bone density, also a loss of bone density over time. So just a reminder that this is a population for whom screening using the FRAX score or a DEXA screen would be appropriate. In the last 6 minutes of this brief overview, I wanted to talk about managing the menopause in women with HIV. So first are the strategies to offset the effects of menopause, which include healthy lifestyle choices, of which smoking cessation is a key component, and then adherence to effective antiretroviral therapy. There's limited data on hormone replacement therapy, and I'll talk about that in a few slides. The use of statins for their anti-inflammatory properties, symptom management, mood and mental health interventions, and then alternative therapies. So in this nice review, they presented an algorithm for the management of menopause. So HIV positive perimenopausal women should have their usual general health or risk assessment, which includes their annual pap smear, breast exam and mammogram, cardiovascular risk profile, mental health review, and lifestyle issues including weight, diet, exercise, alcohol, and smoking. And early on, this could be with the view to anticipating changes that will occur around menopause, assessing for symptoms of the menopause, and then assessment of bone density. Once symptoms are reported, it's important to exclude other causes, and these can be not related to HIV, so depression or thyroid or drugs side effects, or these could be HIV related, including OIs, malignancy, and including lymphoma. A review of lifestyle choices, including smoking cessation and art adherence, and then there are some alternatives for hot flushes among HIV positive women, and these include SSRIs. However, the SSRIs have not shown consistent effects, and they can inhibit cytochrome P450. So this is something to bear in mind. Venlafaxine and SNRI has shown more consistent effects for decreasing hot flushes among HIV positive women. And for gabapentin, there have actually been 3 randomized controlled trials that have consistently shown a decrease in the intensity of hot flushes, and this has the advantage of having no interactions with antiretroviral therapy. And clonidine is another example, but I didn't find any studies that looked at clonidine among HIV-positive women. This table from a study from a review paper by McPheeters and colleagues summarizes the interactions. So because many ARTs are metabolized in the liver and are metabolized by cytochrome P450, this is something to pay attention to. And the 2 main classes would be NNRTIs and protease inhibitors. So that's why this table really focuses on those 2 classes of antiretroviral therapy. And you can see with hormone replacement therapy, which I'll talk about last, there are certainly interactions between HRT and both those classes of antiretroviral therapy. There are no interactions known with gabapentin, oxybutene. There are no interactions known, and desvenlafaxine, there are insufficient data regarding the interactions. So there are some studies looking at complementary therapy. So there actually are randomized controlled trials of omega-3 fatty acids and soy-derived isoflavones, and those have been those decrease symptoms, sometimes just the frequency, but not always the number, or sometimes just the intensity, but not always the frequency of symptoms. Black cohosh, I just wanted to note, has serious liver reactions have been reported, and actually in the UK there's a warning against using black cohosh for menopausal symptoms. Topical estrogen creams can allow local administration, and they're not associated with the same effects as systemic hormone replacement therapy. And acupuncture and yoga, there have been some studies that have shown some effect. This table that I wanted to share with you compared the interventions you might use for menopause for HIV negative and HIV positive women. So for HIV negative women, the data do support a short course of hormone replacement therapy for a shorter duration as possible, but there really are no studies of hormone replacement therapy among HIV positive women. And then for non-hormonal treatment strategies for menopause, oxybutyn is used among HIV negative women. More data is needed for HIV positive women. SSRIs could be used with a note to pay attention to which specific one you're wanting to use and interactions with the ART. Gabapentin can be used. Omega-3 fish oil and isoflavones could be used. And then in addition to black cohosh, red clover is also contraindicated because of interactions with other medications. And exercise, yoga, and acupuncture have been recommended. To come to talk about, in the last slide, hormone replacement therapy. So it was the standard of care for menopause until strong associations were shown with breast cancer, with invasive breast cancer, stroke, coronary artery disease, and pulmonary embolism. And so now the recommendations for HIV negative women are for the lowest effective dose in the shortest possible time. There's no guidance for HIV positive women, and the risks will outweigh the benefits if women smoke, are overweight, have had a history of blood clots, breast cancer, diabetes, have high cholesterol levels, liver problems, or a family history of heart disease. And estrogen and progesterone can interact with ART, specifically PIs and NNRTIs. Integrase inhibitors and entry inhibitors have no known significant interaction. So just to end the talk, so for an uncomplicated HIV positive woman, the same treatment options that we use for HIV uninfected women are probably worthwhile. We need to be aware of drug interactions. There is this huge gap in research for evidence for clinical practice on how to treat menopause for HIV positive women, but given the increasing life expectancy, this is a priority for future research. Very happy to take questions. Thanks so much for your attention.